Good morning, everyone. Thanks for joining us for the PG clinical lecture series. We've finished our section on endocrinology, and from now we'll move to nephrology series. The next 6 lectures are planned from nephrology. Today we'll have a first nephrology lecture, which is based on diagnostic tool of urine analysis and the interpretation of the same. We are happy to have Dr. Anant from nephrology, who's an assistant professor in the department, to take the lecture for us. Thank you.
Good morning. Thank you for this opportunity from your department. It was very short notice. Actually, I got 5 days, and but the better thing was they said to emphasize the proteinuria and hematuria. So that's where just looking today. So my name is Anant. Basically, I'm from Nagpur, Maharashtra, and I'm very fortunate. Like I am just did my DM here. So today we'll see the how we'll approach the hematuria and proteinuria in kidney diseases. Particularly, you also people come into the most of the our patients during your routine practice. So it will be quite helpful for you. So if we go in the past, actually, this Thomas Willis was the first who correlate with the urine analysis and the diseases. He particularly focused on the what he did. He just tasted the urine of the patient, and he found it is a sweet. So he then frequently used to taste the urine how it is. So sometimes he said it's very sweet, and sometimes it's just like flavorless. So he coined the just like name the term like the sweet as a honey and flavorless as a. So he coined the term like not the kind of term, but he just name it as a for the sweet urine as a diabetes and the flavorless urine as a insipidus. And the patient who are passing lot of urine, he named it as a polyuria or a diabetes. So this was the first person who correlate this clinically, and the same things. The center is sitting, and he made one calendar. This is the calendar, and this is the different kinds of the urine, and depending on the taste, color, and appearance of the urine. That was the 3 aspects of his urine analysis. So this was published in the 15/6, and he is available in the Shakespeare's library in the Paris. So after that, this one we can apply till now. In the 13th century, this Corbel, he wrote the poetic like, if the urine is wine colored, it means danger of the health when it is accompanies the continued fever. A caustic humor influences the kidneys in fever. And if there is overmuch coitus, running, and so a lot of exercise, it produces same signs in the healthy body also. So blue-black urine follows the pattern too. So we can apply this till now from the 13th century. So we are the nephrologists. If there is, if we have saw any patient and if labs are available, if there is no urine analysis, we can't move forward. And we got disappointed. Oh, why they have not done urine analysis? They have done complement, they have done NCAS, everything, but they have not done urine analysis. So urine analysis is the first most important thing for us. So we are like peacemongers, like old, and we always look and we'll be very happy if there is a first investigation available to his urine analysis. After that, this Thomas Edis, what he coined, it is very like important for us. When the patient dies, the kidneys goes to the pathologist, like you can say. But if he lives, the urine is ours. So it can provide us a day by day, month by month, or year by year, a serious story of what the major events going inside the kidney. Like either it is encapsulitis, either it is a lupus nephritis, any kidney disease. Like there's a chronic kidney disease also, or a diabetic nephropathy also. So that's why we are monitoring and we are following our patient with urine analysis till the patient is with us. So now what the current scenario is, we are the, like I told you, as peacemongers of like old. So we still cradle the vials of the amber liquid while holding hands. It is not current practice, but when I did my MD, I just remember our HOD was like, you can say, he was old. He finished his DM cardiology in 1976 from the BHU, and he was our HOD. So what we have to do, we have to put our urine, whatever the urine analysis, we have a side room, that is we call it side lab, and we had a microscope. We have to prepare a slide and we have to show him that these are the cast we have seen, or there's the RBCs we have seen. And for protein analysis, we have to put urine in that glass tube, and we have to heat it. Because so depending on that, why there is a 1 plus protein or 2 plus protein or 3 plus protein. So like that way we were using in our MD preds, but unfortunately we are not using microscope here. And my native place, when I did my MBBS, still we had the MD pages they are doing, still using the microscope and analyzing the urine. So it is very actually important practice. Everyone should know to see the under microscope how the RBCs and how the casts are looking. Unfortunately, I am not told to cover this cast part, some crystals and everything, that all urine analysis. But that is also very interesting part of the urine analysis. So how to examine this? This is the third most common actually clinic laboratory investigation after the complete blood count and basic metabolic panel. It's the third most common investigation to be done. It is a time-honored test. I told you that like some 13th century it is going on, and it is still valid. So this is the time-honored test, and we have to honor this urine analysis always. It's a urinary biomarker for various kidney diseases. So either it is acute kidney injury, either it is interstitial nephritis, either it is a glomerular diseases, either the nephrotic syndromes, either it is a nephritic syndrome. It is a urinary biomarker to differentiate various kinds of the syndromes. It identifies the compartment of the injury also. Either it is the interstitium, either it is the glomerulus. And even in the glomerulus, either it is the GBM, either it is the mesangium, or either it is the podocytes. It identifies which compartment of the kidney get injured. So not only this, it guided the therapy and to assist in the monitoring and progression of the kidney diseases. So it is called as a liquid biopsy. We know the kidney biopsies, but it is called as liquid biopsy because it tells us the cell morphology, epithelial cell, reticular tubular cells, and RBCs, dysmorphic RBCs, WBCs. It also tell us about the cost. Either it is a granular cast, or either it is associated with the acute tubular necrosis, that is a muddy brown cast. And it also tell us about the various crystals that is associated with the drugs. We know the acyclovir, for example, I'm telling you. So it also tell about the crystals, and it also enable the rapid diagnosis of the either acute or chronic kidney diseases. So as we just focus on the hematuria today, it is particularly, you can see in the nephritic syndrome, with the most prominent finding is the dysmorphic RBCs. That is called as acanthocytes, or isomorphic RBCs, WBC, WBC cast, and red blood cell cast. Other, if you say prenatal urine, the urine sediments are most time the bland. In acute tubular injury, reticular tubular epithelial cells, interstitial nephritis, WBCs and WBC cast are prominent. In nephrotic syndromes, because of the proteinuria, droplets you will be see. And if you know the Maltese cross in a dark field microscopy in the nephrotic syndrome, you will be able to see the Maltese cross. And in osmotic nephropathy also, there is a tubular cells. But there are the limitations to this analysis. Sometimes it may be bland in the acute interstitial nephritis. Even in the proliferative G1, it might be a bland. And in acute tubular necrosis or injury, it might be a bland. So first part will be the hematuria. So hematuria might be isolated. It might be because of exercise or a prolonged recurrency. It might be an intermittent and persistent. Then we have to consider the pathological. The causes of hematuria next to come, we can divide it into glomerular causes and non-glomerular. Non-glomerular on your right side, it is mostly urological causes. So in the glomerular, we know the IgA nephropathy is the most common cause of the hematuria, followed by the thin basement membrane nephropathy. And focal segmental glomerulosclerosis, lupus nephritis, there is a proliferative GNs, including the crescentic GNs and the infection-related GNs. Even the membranous nephropathy and mesangiocapillary nephropathy, the hematuria can be seen. In non-glomerular causes, the ADPKD, exercise hematuria, bleeding diastasis, and drugs, including the anticoagulants. In the urological causes, you can see the urinary tract infection, that is the most common cause in the pediatric age group. The pediatric patient mostly present with the hematuria. And another things in the adult patient, urinary calculi, hypercalciuria, prostatic hypertrophy, even in the renal cell carcinomas, prostatic carcinomas, excised stoma, and bleeding diastasis, drugs, and papillary necrosis mostly in the patient with the diabetes and sickle cell nephropathy. So when to investigate the hematuria? If the hematuria, patient present with the hematuria and it is a persistent, and if it is present in the repeated samples, for at least 3 samples we require, that is showing the hematuria. So how to approach to the isolated hematuria? If the patient you came, but it is asymptomatic and is having RBCs of more than 3 per high power field. So just we have to rule out either if the patient is female, either it is menstruating or not. He has done like a heavy exercise, or he came from the gym or like that, or he had a known history of any nephrolithiasis or not. If it is absent, then we have to repeat the urine analysis. If there is a persistent hematuria, then you have to look for the glomerular causes. In the urinalysis, if the RBCs are dysmorphic, then suspect the glomerular diseases and proceed for the serological workup. If the proteinuria is more than 500 milligram per day, that is a 24-hour, then it is an indication for the kidney biopsy. If all these things are not then it is considered the urological causes of the hematuria. If there are the risk factors are there, if the patients are old one, like you can say more than 35 years old, either have received some cyclophosphamide, you can consider a renal cell carcinoma, and you can proceed with a CT urogram, but and urological referral. But there is no risk factors for the bladder cancers or some renal cell cancer, then you can evaluate it with the ultrasound and you can follow it with the CT. So how to define hematuria? We can categorize as a microscopic, glomerular, and isolated. So microscopic hematuria, if there are the more than 3 RBCs per high powered field, we define as a microscopic hematuria. For the glomerular hematuria, what is the most characteristic features are the acanthosis. That is more than 5%. Okay. The second particular feature is autism. That is more than 40%. There are variation. So sometimes you also sending the phase quantum microscopy, and you are just reading sometimes 10%, 20%, 30% dysmorphic organism. But actually, the dysmorphic organism has a very low sensitivity to call it as a on that urine analysis, phase quantum microscopy. It is low sensitivity, but it has high sensitivity. So basically, the counts are more than 40%, not like more than 10 or 20 or 30. So if the counts are more than 40%, it is possible. And if the counts are more than 80%, it is a so now we need to sample positive for all more than isolated microscopic hematuria is hematuria without a significant proteinuria or there is a no renal dysfunction. The creatinine is normal and there is no significant proteinuria. It is called as an isolated microscopic hematuria. For the isolated microscopic hematuria, there is no need to do a kidney biopsy. We have to just follow the treatment. If the proteinuria remains persistent, then there is an indication for the kidney biopsy. So as I saw, the glomerular hematuria is mostly dysmorphic and urological is mostly this isomorphic. So how to collect samples? So spontaneous voiding is the preferred one. So first void midstream urine. Why will you use midstream urine? Because doing the first voiding, whatever the urine in the bladder, the epithelial cells and whatever the contamination urine, we get flushed with the voiding, and that's why we have to collect the midstream sample. Okay. We can collect a random specimen, but the specificity of the random specimen that we have to collect any time a day, it is very low actually, because you know what happens sometimes, because overnight samples if you collect and you collect the first sample, there will be a lot of contamination, including epithelial cells and including bacteria contaminants. If you collect urine in the evening, if the patient remains standing for the lot effect, so orthostatic hematuria also happens in other patients. So it may give a false value. So random sample specimens are not preferred. So we prefer a sample is the morning sample, that is the first white, and midstream. In patient who are not able to pass, or you said it is definitely there will be contamination. So you can use a catheter. So it is a straight in and out catheter. You put a catheter, collect the urine, that will be the benefit. Another, if the patient having indwelling catheters, so you put a fresh catheter and you have to collect the urine from the tube after puncturing the sterile collection. If the patient not able to pass the urine, then suprapubic collection, it is mostly used for the cultures. 24-hour urine sample collection, mostly we are using for the 24-hour quantitation of the proteinuria. And if the patient is having urostomy or ileum condition specimen, there is no other way to have a urine, then we have to put a catheter inside the country and have to collect. After all, sterile precautions. So our scheme for today for urinalysis is the direct observation followed by the dipstick analysis, microscopic analysis, and biochemistry. So direct observation, we all know the urine might be a red because of lot of things like this, so hemoglobinuria or hematuria, myoglobinemia or methemoglobinemia. I just highlighted those who are very come to our practice very frequently. So porphyrin and the diet, including the beets, carrots, these are the mostly patient present with the red color urine. Another drugs including the chloroquine, L-dopa, phenytoin, metronidazole, and nitrofurantoin. These are the most common causes of drug-induced causes of the red urine. So what is the technique? So we have to, after the sample collection, we have to analyze this urine within 1 to 2 hours, not more than that. And if we don't have a lab nearby, then we can refrigerate our urine at -2 to -4 degrees Celsius for 8 hours. So within 8 hours, we have to analyze, not more than that. So test tips, they can detect the hematuria, but it is not reliable because it might detect the heme also or myoglobin also. So it depends on the erythroperoxidase activity. So for confirmation, we have to do urine analysis. So urine microscopy only, that will confirm the microscopic hematuria. So how to proceed for the counting dysmorphic orbicits? So at least 10 ml of urine we have to get, and that should be centrifuged or high unit. The centrifugation will be around 500 gravitational force. Gravitational force means the distance of the tube from the center of the centrifugation, or you have to rotate at the 2000 rotation per minute. So 9.5 ml of the that supernatural you have to discard by the pipette only, and 1.5 ml substitution you have to use for the examination per minute. You have to put a single drop of the element on the slide, and this increase your yield by around 24. So how to check the validity? If the RBCs are less than 20 in uncertificated urine, then not diagnostic. If the sample is contaminated with the WBC more than 30 into 10⁶, then it is a contaminated sample, and we have to discard such samples. So we can examine this in the low field, that is the same like the original magnification, or high field, 49% of the original magnification, right field or phase contact magnification. The right field we can use, but it will not help that much to get a dysmorphic orbicity. So the preferred phase contact, and that is a mandate. So every time you are microscopic hematuria, if every time you want to microscopic hematuria, you have to ask them to get a phase contrast. That is a mandatory according to the European and American Society of the Nephrology. These are the mandatory, the phase contrast. So we have to see the at least minimum 10 fields. The optimal 10 fields are 20. So each pore we have to see. And we have to see at the margins of the cover slip, because that is site where the maximum concentration of the RBCs get accumulated. So I just told you phase contrast is a mandatory, and we can use also, if we don't have phase contrast, then we can use a bright field also. But for a bright field, we have to use a lower the condenser, we have to just lower it, or we can use a supravital stain like a white stain to distinguish between these isomorphic and dysmorphic RBCs. So we have to count at least minimum 100 RBCs to classify the morphology of the RBCs with 10%. Always there is the uncertainty of 10%. So you can see this is the bright field versus phase contrast. The above your left is the RBC cast. That is the RBC cast in the bright field microscopy, and that is the acanthocyte. You can see on your right side under the this is the acanthocyte under the bright field microscopy, but with lowering the condenser. After the lowering the condenser, these two images are showing the acanthocytes in the phase contrast microscopy. The acanthocyte we can see like that. This you can see there's a bleb. So this is the characteristic feature of the acanthocytes. The bleb protruding from the ring-shaped RBC. So this is the phase contrast microscopy. The same acanthocyte with the bleb. It is a base method to assess the acanthocytes, and it's better the method to identify the RBC dysmorphism. And this actually we can use another with the ghost RBCs. So you can see in the urine. What are the ghost RBCs actually? These are the
with thin membrane. RBCs, you will like a thin membrane. I will show image if you have. This will be the thin membrane with loss of hemoglobin inside the RBCs. So ghost RBCs can be detected only in the phase contrast microscopy. That is another kind of the dysmorphic RBC. So for this, there is a new uniform definition for the dysmorphic RBCs. There are the total 9 RBCs, different kind of RBCs have been defined by the Kohler in his actually very landmark study. It came in 1991. He defined 9 types of dysmorphic RBCs. So we'll go to some studies. Actually, in 1982, this Pelly and Breachy examined the shapes and of the urine RBCs. He took 58 patients that were the glomerular disease patient and 30 patients which were the urological. So he found that 55 out of 58 patients having the dysmorphic RBCs in the glomerular disease, but none patients were found with the urological diseases with the dysmorphic RBCs. As I told you in 1991, Kohler et al. He characterized the possible shapes of the dysmorphic RBCs. So he demonstrated 9 types, different types, and one characteristic he noted was the acanthocytes. He characterizes the acanthocytes. Since then, we use the acanthocytes as the characteristic picture of the dysmorphic or microscopic hematuria of the glomerular origin. So here we can see why we are using the dysmorphic RBCs of the more than 40%. You see that highlighted study done by the Cope et al. He found that if the dysmorphic RBCs are more than 40%, the sensitivity is, though low, it is only 20%, but the specificity is almost 100%. Why we are using this? But he used the biopsy proven GN. The rest of the studies did not use the biopsy proven GN. Another study, that landmark study by the Kohler, he used the acanthocyte more than 5%, and he found the specificity of 98 to 97% to diagnose as the glomerular diseases. So these are the acanthocytes on your So this is the on your right. This is acanthocytes in right field microscopy. On your left is the phase contrast microscopy showing the acanthocytes with the blebs. On your left, this left lower side, this is a electron microscopy, and this is called the electron microscopy. The magnified view. It is called the ring shaped with the bleb, and it is called the G1 cell. It is called the acanthocytes are also called as the G1 cells because these are the specific for the glomerular diseases. That's why it is called the G1 cells. So these are the 9 types of the dysmorphic RBCs. We'll see one by one. So the first one is discocytes. It's a disc form RBCs with concentric cavities. You can see the 2 concentric cavities. The another is echinocytes. It has the types 1 to 4. When the spicules are uniform, it is a discocytes type 1. And if the spicules are fading up, it categorizes as echinocytes 2 and 3. When the spicules are completely fade up, it is called as the echinocytes 4. You see this this one, this is the 4, and this is the first. The annulocytes, next one, this is the erythrocyte with a dense membrane. You can see like a membrane becomes dense. The ghost cell, as I told you, the membrane becomes thin with loss of hemoglobin. The schizocyte, these are the fragmented cells. Oh, sorry, schizocytes, something missed. Yeah, schizocytes, these are the fragmented cells. The stomatocytes are the RBCs with a single concavity. The RBC, we know the biconcave, but these are the single concavity of the stomatocyte. Podocytes, these are the ring type cells. Bell type shapes. And the mesocyte, these are the triconcave cells. And the acanthocytes are the RBCs with the blebs. So we'll see the mechanism of the dysmorphism. So we know the RBC is having the size of the 6 to 8 micron, and the endothelium filtration have the size of 60 to 80 nanometers. That's the RBC size of 1,000 times more than the fenestration. So this integrity of the RBCs, sorry, this microscopic hematuria is prevented by this integrity of all these things, including the glomerular capillary hydraulic pressure, GBM integrity, and the erythrocyte membrane deformity. The GBM glomerular basement membrane completes three components. It has like endothelium, glomerular basement membrane, and the podocytes. So all these three, if any defect in all these three, the dysmorphic urine will see. So you are able to see in the your right side image. It is actually and this RBC gets deformed while it's exiting from the capillary loop to the urinary space. The same thing with the electron microscopic feature. The RBC is coming from the capillary loop toward the urinary space, and it is getting deformed. So the step by step how the RBCs, this is a real time actually electron micrograph, how the RBCs was coming from the capillary loop to the urinary space. In the figure F, you can see. Along with the RBC. So I told you. So the mechanism is a small rupture in the GBM, either because of the lysosomal digestion, because of the immune complex deposition, or basement membrane focal ultrastructural abnormalities. Either it is thinning or lamination in the thin membrane nephropathy. So another mechanism is because of the differential pH of the or osmotic forces in the tubular fluid. If the tubular fluid osmotic pressure of the tubular fluid is high, like it is very hypotonic, it is very hypertonic, the RBC gets shrink. If the fluid is hypotonic, the RBC will get swelled. So if this will lead to the change in the size of the RBC, and if already there is a GBM any disruption is there, and the RBC tries to pass to that GBM, the RBC will get dysmorphic. So in this image, you can see this is the actually. So as I told you before also, dysmorphic RBCs, if the cutoff value is 40%, it is the possible hematuria, and it is 80%, it is the probable hematuria. And for the acanthocyte, if there is more than 5%, it is 90%, and the hematuria was called as a probable. So how to assess for hematuria? We have to just see for the clinical scenario and ask the question: either it is a glomerular hematuria, either it is a tubular hematuria, either it is a post-renal hematuria. So then we have to ask ourselves the site and pattern of the injury. Either it is a tubular injury, either it is a glomerular injury, either post-renal injury, and then how to analyze finally. So first clinical question we have to ask is either it is a glomerular or non-glomerular. How much is the glomerular damage? How is the any evidence of proteinuria is there? Or any evidence of tubular damage is there? Or any evidence of tag disease is there? So for injury, we have to just assess the site of injury, what is the type of injury, and extent of injury. So site of injury, either it might be glomerular or a post-glomerular or urological. Type may be either it is a immunological, non-immunological, or extent, either it is a rapidly progressive, or it may be chronic disease, or it may be acute injury. In the glomerular diseases, hematuria, though it is a cardinal site of nephritic syndrome, but it may be found in the nephrotic syndrome also. So in minimal changes, it's found in around 30% of the patient, in around 40% of the patient, and nephropathy almost around 50% of the patient. Even in the diabetic kidney disease, we see if it is we are looking for the hematuria to rule out the non-diabetic kidney disease. Even in the diabetic kidney disease, it's found in around 35% of the patient. So in glomerular diseases, IgA nephropathy, as I told you, is the most common cause, followed by the nephropathy, and followed by the NPC. So IgA nephropathy is the most common cause of asymptomatic chronic hematuria, and if the persistent hematuria is there, that to be microscopic. Actually, if the patient presents with a macroscopic hematuria, so those patients get detected very early, and they have a favorable prognosis. But the patient have persistent microscopic hematuria for a long time, this patient have a poor prognosis, and they have a 2.8-fold greater risk of kidney failure. In ANCA vasculitis, the utility of the urine microscopy is to diagnose and to monitor the disease process. The vasculitis score deems presence of hematuria. It mentioned as active disease. It is persistent hematuria. It is say that is an active disease. We just move for the case. So, a 25-year female, she present with a fever for 1 month with oral ulcers and arthralgia and blood pressure of 110/70. She had edema of lung plus, pallor 1+, and chest is clear. On laboratory evaluation, urine shows 2+ proteinuria, acanthocytes more than 5%, creatinine is 0.5, hemoglobin 10, and platelet
2,50,000. 24-hour urine analysis shows 300 milligram. So complements are low, ANA and dsDNA both are positive. So what will be the next line of management? Anyone, please? You will proceed for the repeat testing and follow the progress, or to do a kidney biopsy, or to treat as an extrarenal lupus. You will consider both ANC as the correct, or you consider as all of the above. Anyone? Huh? Kidney biopsy. Okay. Sorry. Repeat the testing and follow the progress. Yeah. What about the C? She has a fever. She has oral ulcers. She has arthralgia. Sorry. Yeah, I have gifts also, actually not gifts, but for correct answers. Yeah. So that was repeat testing and follow was the correct answer, but more correct is like A and C to treat as an experiment. So the correct will be actually what I'm just prepare this one case, because a lot of times from the rheumatology and medicine cases are coming to us to do a biopsy. Okay, so if the patient is there is the creatinine is normal, patient is having microscopic hematuria, but proteinuria is not significant. That means renal manifestations are very less, so there is no indication of kidney biopsy. We have to follow such patient. If the microscopic hematuria is persistent, proteinuria is worsening, then it is an indication for the kidney biopsy. Okay. So this lupus nephritis, the SLIC classification criteria also mentioned as a RBC cast is a marker of the lupus nephritis, and isolated hematuria is a marker of the proliferative element. Our KDIGO guidelines also mentioned that hematuria and acanthocyturia is positively correlated with the proliferative lupus nephritis. So we have to screen and monitor the lupus nephritis activity accordingly the microscopic hematuria. So another case, 60-year gentleman, known diabetic, nephropathy, it's a biopsy proven. The baseline K was 2 and eGFR of 40. The trajectory of fall of eGFR around 2 to 4 within the last 4 years, and the UACR that is was around 150. Why I mention UACR here? I will tell you later. And he presented with a 2-month history of fatigue, anorexia, and unintentional weight loss of around 5 to 6 kg. On examination, pulse is 80, blood pressure is 140 over 80 mmHg. He had mild pallor, mild edema, but chest is clear. Lab showing HB of 10.3, WBC is 8,200, platelets 2,30,000, rate of 4.12 increased, and eGFR of 20, fall to 20 from the 40, potassium 5.7, sodium is 137, bicarbonate 20, serum albumin 3.2. Analysis shows 2 plus proteinuria and 3 plus RBCs, and microscopy shows RBCs 10 per high power field, including dysmorphic RBCs. So which of these is the most appropriate response with regard to this man's condition? He has lost a significant amount of weight in the recent past, which has resulted in the rise in creatinine, or he has evidence of significant acute injury, which can be managed conservatively. This is the natural progression of underlying diabetic nephropathy, but this patient might need further investigation to rule out the NDKD, including the kidney biopsy. So his create was 2, baseline increased to the 4. On evaluation, there were urinalysis 2 plus protein, 3 plus RBCs, dysmorphic RBCs, showing more than 10 per high power field. So there is a worsening of the eGFR within the last 2 months. Like it was 40, it was 20. So what will be approach? Sorry. Who was basically with the D from beginning. So other forms of hematuria, that is the non-inflammatory, we can consider we having Alport syndrome. All males with X-linked will have hematuria, and females with autosomal recessive, male with autosomal recessive. Another we can found in the thin membranous basement membrane nephropathy. Inflammatory C3GN and IRGN, anti-GBM diseases, and anticoagulation related nephropathy. We'll move to the proteinuria. So what is the value of proteinuria assessment? Can you anybody tell why we are doing proteinuria assessment? Anyone? Means like as your own guessing why you are sending proteinuria, either it is a UPCR spot or a 24 hour. Anyone? Why are you doing proteinuria? Yeah, tell me. It will be because it will be very boring if I just talking and you are not talking. That's why I bring chocolate, that actually we will talk. So I just try to give a bar big. Okay. When you are this place, please. Anyone? Sorry. Yeah, monitoring diabetic nephropathy. So actually, the good comment like monitoring diabetic nephropathy, there is just so first, when you are suspecting the glomerular disease, the first patient will present with the hematuria and then the proteinuria, even before the drop in the GFR. So it is a why we are monitoring to see the treatment response and to follow the prognosis of the patient. Not even the AKI, but not even the kidney disease, chronic kidney disease, but even the GN. So another important aspect of the proteinuria is it tells us the pathogenesis of the renal injury and disease progression. Why it tells the pathogenesis? Because proteinuria, it will tell the site of injury also. Either it is because of the podocyte injury, either it is a mesangial injury, either it is a GBM injury. So that's why we have to monitor the proteinuria. And why? Because the quantitation of the proteinuria will vary and the association with the hematuria will vary according to the site of injury. If it is a podocyte, you can see a dominant proteinuria. If it is a mesangial environment, you can see the proteinuria. Either it is a subnephrotic or nephrotic, but most of the time it is the hematuria. If it is a GBM, it will be the prominent hematuria and proteinuria will be not that much. But another also thing is these all GN patients will have a tubular proteinuria also. Why it will have tubular proteinuria? GN patients. Glomerular proteinuria means like albumin, and tubular proteinuria means non-albumin. Have a tubular proteinuria also. Why? Okay, because in the GN, as the GFR declines, the capacity of the proximal tubule to absorb the protein is declining. That's why this patient presents a tubular proteinuria also. So normal physiology, if we consider as a normal GFR around 100, at this level the adult person weighing 60 kg will produce around 180 liter of urine per day, which contains around 10 kg of protein. But out of which around 0.01% or 1 gram of protein passes through the glomerular filtration barrier into the filtrate. So this glomerular filtration barrier, I told you 3 components of the glomerular filtration barrier: endothelium, glomerular basement membrane, and podocytes. These act as a size, shape, and charge dependent permeselective molecular barrier for the proteins. And damage to any one of these 3 components of this glomerular filtration barrier leads to the glomerular proteinuria. So this high molecular weight protein, including the albumin, it has a 67 kilodalton molecular weight.
So it can't pass normally through this glomerular filtration barrier, and this filtration barrier restricts the albumin. Low molecular proteins, that is less than 20,000 kilodaltons, including the alpha microglobulins, apoproteins, enzymes, and peptides. These are mostly tubular. So this excreted in the very small amount of the urine. And so whatever the amount of urine appears in the protein, that is 150 milligram or less, it is a tubular proteinuria, not a glomerular proteinuria. So these are the types of proteinuria: glomerular, tubular, and overflow proteinuria, and post-renal proteinuria. So we'll see one by one. So glomerular proteinuria that I told you, because of the damage of the glomerular filtration barrier. Tubular proteinuria, that is a low molecular proteinuria. Overflow proteinuria, anyone? Examples? Sorry? Yes. Who's the then anyone? So another is severe hemolysis. Hemoglobinia is the overflow proteinuria. So clinical relevance, we see case 3. She's a 26-year female present with the swollen legs for past 3 weeks. She was on ibuprofen 800 milligram thrice a day for 1 month for a shoulder injury. Her blood pressure on examination was 130/90, and he had a 3% lower extremity edema. Urinary she shows 4 plus proteins, no RBCs, and 24-hour urine protein was 10.8 gram. Creatinine is 0.9. So what is the most likely glomerular location causing this clinical picture? Either is a IgA nephropathy, either is a Alport syndrome, either is eclampsia, is a RPGN, or a MCD, minimal change disease. Yeah. Yeah, we don't have sediments, we don't have renal dysfunction, only proteinuria of whole pus. So it's a podocytopathy. Another case, 20-year-old Asian female. I'm just mentioning Asian. It's not like random Asian, but it's why we are mentioning Asian, because this is more common in the Asian population. So she presented 3 episodes of macroscopic hematuria over the past 6 months. Examination shows blood pressure of 140/90, and lab showing creatinine of 0.9, urine showing 15 RBCs per high powered pill, and protein of 3.4 gram. That is a nephrotic proteinuria. Native kidney biopsy was performed. So which shows either it is a minimal change, IgA, anti-GBM, or lupus. Yes, who will go with minimal change? No one. Okay. Who will go with IgA? Who will go with anti-GBM? Who will go with LN? No one LN? Okay. So it's actually IgA. If the injury is in the mesangium, the prominent finding will be the hematuria, and the proteinuria will be not much. So glomerular hematuria, it's a result from the damage to the podocytes, GBM or glomerular endothelial cells, and it has it's because of the loss of charge and site selectivity. It's predominantly actually albuminemia, as I told you, and ACR and PCR usually more than 40%. Often results in the urinary protein loss of more than 1 gram per day, glomerular proteinuria. So magnetic proteinuria can vary, and it can go above also 10 gram per day. Tubular proteinuria is because of the damage to the tubules, and as I told you, the patient with the glomerular disease even, or even the patient with the tubular diseases, it inhibits the capacity of the proximal tubules to absorb the protein, and that's why there is the tubular proteinuria. So it's mostly low molecular proteinuria like the alpha 2 microglobulin, and the causes, we can see as the causes of the like Fanconi syndrome and Den disease. Overflow proteinuria, I told you, like plasma cell dyscrasia, myoglobin, and hemoglobin. Is because of the in multiple myeloma, the PCTs are not able to absorb that much protein. That's why there is overflow protein, it's called as. In post-renal proteinuria, that is a urological mostly, it is very small amount, and it will be urinary tract infections or calculi, and it's mostly non-albumin, including the immunoglobulins, IgG or IgA. So what is the diagnostic utility? So actually, simultaneous measurement of different types of urinary proteins may be useful to differentiate between the either glomerular, tubular, or post-renal proteinuria. Albuminuria is predominant in the glomerular diseases, and higher albumin to total protein ratios obtained from the simultaneous measurement of ACR PCR, which signals the glomerular rather than the tubular proteinuria. So how will define the proteinuria? If the proteinuria is more than 150 milligram per day in 24 hours and 140 milligram per meter square in children, it is called as a proteinuria. Anyone can tell in pregnancy how we define proteinuria in patient with pregnancy? It is 150 or something else value? In pregnant patients, above which we, now in normal patient we consider as a 150, above which 150 is abnormal level. In pregnant patients, how much we consider? Yeah, we consider 300. 300 is the pregnant patients. In previously it was in diagnostic criteria, so more than 10 was included, but not now mandatory criteria. Okay, so it is the additional criteria that more than 300 milligram for 24 hours is an additional criteria for diagnosis of the preeclampsia. So how to categorize the proteinuria? So if it is the albumin creatinine ratio, these are the previous definition, that is old definition, old terminology like normal to widely, moderate linkage and severe linkage. So now ADCO defines as a A1, A2, A3. We have classified, and it is like so I just told you kiddicotomy is normal to mild link is less than 30, moderate link is 30 to 300, and severe link is more than 300 milligram per day, and nephrotic range more than 3.5 gram per day. So how we most common method and most sensitive method to assess the protein is turbidimetric method, and to evaluate for albumin, that is the immune turbidometric method. These are mostly preferred. These methods are we can use the chemical burette, turbidometric dye binding. But for albuminuria measurements, we use the turbidometric, and over that it is the immunoturbidometric. But most sensitive to detect the protein is the chemical burette method. It can detect as much as low as 50 milligram per liter. So some errors also there in measurement of the proteinuria. If the patient have a long-standing posture,
it can have a cause to increase proteinuria. If patient has UTI, hematuria, high dietary intake, high intensity exercise, congestive cardiac failure, and patient, if it is menstruating, having vaginal discharge, or including patients taking NSAIDs, it will falsely increase the proteinuria. In analysis phase, pre-analysis, how we collect the, either it is a time, that is a 24-hour collection, or random collection, not timed collection, or when we collected. Another thing is, if we store the sample for the long time, it may lead to the degradation of the protein or lead to the absorption of the protein into the plastic container. In analysis, either it is a total protein is measured, or either the albumin only is measured, and what assay type is used. If we use the immunoturbidic method, that will be the most correct method. So why will try to quantify proteinuria? It is having a disease-specific relevance for the prognosis and treatment decision making. The level changes of the proteinuria used to categorize the risk of disease progression as well as the clinical response to the treatment. So even in the glomerular diseases and now in the non-glomerular diseases, also including diabetic kidney and even in the CKD having the proteinuria, we are using the SGLT2 inhibitor to decrease the proteinuria and as a renal protective. After this, these are called the four. I just like out of that the four pillars like the ARBs or ACs inhibitors, SGLT2 inhibitors, and Kindinol. These are the pillars of the renal protection. These are the coming new orders. So when we are starting SGLT2 or ARBs, we are monitoring the proteinuria, how it is responding, and we are optimizing our ARBs as SGLT2 depending on the proteinuria. So these are the benefits of quantifying the proteinuria. So preferred method for proteinuria assessment is 24-hour is the preferred method, and it is also called as the gold standard for the proteinuria assessment, not the ACR or PCR. Why it is considered gold standard? Because it averages the variation of proteinuria due to circadian rhythm. As I told you in the evening, because of prolonged static, the proteinuria increases, and because of physical activity in a posture, the proteinuria increases. So it matches with the circadian rhythm and activity. It avoids the errors introduced by using the spots PCR and accurately measures the all clinical significant types of proteinuria. So how will assay that whatever the proteinuria we have measured is the adequate or inadequate? So it depends on the how the patient creatinine has been in the measured in the urine. So when you are sending the 24-hour urine analysis, always send the 24-hour urine protein creatinine along with that. So in normal persons aged 20 to 50 years, the main exceed 18.5 to 20 milligram per kg per day of creatinine in the urine, and woman 16.5 to 22.4 milligram per kg. And if the patients are old age, these values got declined, and for men it is 15.7 to 20.2, and for women it is 11.8 to 16.1. So whenever you are seeing this 24-hour urine protein, try to see if it is either adequately collected or not. So you just try to see how much creatinine you have mentioned there. And if the patient's age is around, you can say around, weight is around 60 kg, try to multiply male, then try to multiply around 20. If this creatinine is normal range, according to this, then the collection is adequate. If the creatinine this value collected is coming very low, you just assume that this collection is inadequate, and you have to repeat your proteinuria. Sorry, analysis. Yes. In trials also, if anyone trying to do your studies in the any GNs or anything, so you have to use a 24-hour analysis, not PCR ACR, for your analyzing your study. So in trials also, whatever the trials available, they use a 24-hour because in GN the protein is always heterogeneous. It includes albumin, globulin, low molecular protein, everything. So that's why in trials this 24-hour collection is used, and we use this in trials also. This is to assess that they follow the patient for the 2 years or 3 years. They use 24-hour urine protein for the assessment. So there have limitations also. We know that 24-hour limitations because of it might be under collected because they are not following the strict timing. So it might be under collected or over collected. What if we don't have this 24-hour collection? Then we can use a PCR. After this 24-hour collection, PCR we can use. So spot PCR assessment are actually, we are not using that much for the assessment of the glomerular diseases, because for the glomerular diseases, the 24-hour collection is gold standard. But if you use, urine should be collected at the same time. If you are monitoring PCR every time, then it should be collected at the same time a day under the similar condition for monitoring the glomerular disease. So urine ACR and PCR are obtained by dividing the urine protein concentration by the urine creatinine concentration. and expressing the result as a milligram per millimole or milligram per gram. So just I one question I mentioned there. So you are seeing the PCR there in your lab, and you find the PCR protein casing ratio of around, I just make it the question answer. It's a 0.6. So how you will calculate, collaborate with the 24-hour collection? Anyone have reflected that? Because you will use, I think, after this class, you will try to use this also. I mean, anyone know? So our values are mostly in our lab, they are mostly like, right? Yeah. So if so this ACR and PCR, they are used as a, I just, this the same things. If it is given in the milligram per millimole, just multiplied by 10. And if it is given in the milligram per gram, use activities. Or if it is given in the milligram per milligram, then multiply by 1000. So what limitations of this ACR and PCR? There is a daily variability in the excretion and between the individuals also. And there is a fluctuation in the protein excretion by circadian also, by after exercise, after postures. So these are the limitations. Urine protein creatinine ratio, it was developed to minimize the bias created by the urine dilution. And it was used with amount of creatinine in the urine in the single spot urine analysis. So there is a high degree of correlation between the spot UPCR and the 24-hour collection. So what sample we should use for UPCR? It should be the first morning white sample, but it try to underestimate the 24-hour proteinuria by around 20%. And random PCR, random means like any time a day. It will not be ideal. It will have variation over the time, both in protein and creatine excretion. So PCR is used for the monitoring of the for the CKD, you can say, and it can be used to rule out the presence of significant proteinuria as defined by the 24. If you are not able to do 24-hour proteinuria, you can use as a UPCR to rule out just there was no significant proteinuria. If the UPCR protein creatine ratio is 0.00, 0.02 or 0.002 like that, to just rule out it is not significant. If you found the creatine ratio is higher, like 0.5, 0.5, 0.6, 0.7, 0.8, then you can proceed for the 24-hour proteinuria. So this is the use of this UPCR. About ACR, it is not correlating well with 24 hours. So don't never use as a collaboration with the ACR. If the ACR is there, don't try to multiply with 1000. It is not collaborating with the 24-hour urine protein. So this diabetes control and complication trial and EDIC trial, they use ACR for the diabetic patient for the monitoring only, for the monitoring purpose of the diabetic patients. And but it is not used in the non-diabetic patient like the GN patients or some CKD patients. And it is recommended for the categorization of the CKD, which just show the category A1, A2, and A3, and the prognosis. Why we are not used? I told you URCR because this albumin is specifically albumin, but the GN having the heterogeneous protein like the albumin, globin, and all. That's why we can't use ACR in the monitoring of the GN. So ACR and VCR, which is superior? So I told you already that PCR is superior to the ACR. Even in the even the comparison with the 24-hour urine protein. And another thing is UPCR is less expensive as compared to the ACR. So UACR is specifically used to analyze the albumin, and UPCR albumin as well as the low and high molecular proteins. UACR diagnostic value is for CKD, hypertensive disease, diabetic disease, and UPCR you can use for the any kind of proteinuria with but high sensitivity having the glomerular, overflow, and tubular proteinuria. The sensitivity For predicting the 1 gram proteinuria, that is 24-hour, it is only 79%, but PCR it is almost 93.9%. So PCR is more collaborative with the 24-hour proteinuria. So in specific population, pregnant patient, as I told you, is more than 30 milligram per 24 hours. Okay, and children's normal level is more less than 10 or more less than 4 milligram per meter square per hour. Nephrotic range we mentioned more than 40 milligram per meter square per hour, and PCR is having accuracy with 24-hour but not ACR. And in transplant patient we use only 24 hours but not even a PCR. So take home points. Towards approaching the microscopic hematuria, exclusion of the benign causes is mandatory. Just like patient is not menstruating, there is no urological causes, and then how to targeted workup towards the glomerulonephritis or post-kidney diseases. And kidney biopsies are usually not performed if there is isolated microscopic hematuria and proteinuria is less than 500 milligram per day. If proteinuria is more than 150, it is defined as a proteinuria. Glomerular proteinuria is predominantly albuminic, and UACR or UPC is mostly 40%. Tubular proteinuria usually less than 2 gram per day, and it's predominantly non-albuminic, that is a low molecular proteinuria. And UACR is usually used for the classification of CKD and following up the patient with the diabetic kidney diseases. And that 24-hour we use mostly in the patient with the glomerular disease, including the nephrotic syndrome. I think that's all. These are my references. Thank you. I like to apologize if any mistakes or something happened for me, because I'm just like nervous today. This was my first class, so just forgive me for any mistakes. Thank you so much.
So thank you for the interactive and informative class. Any questions to sir?
ACE inhibitors what we use, and you said we monitor. So how often should we monitor? How do we titrate the dose to treat?
I think it is CKD or GN also. Even in the nowadays we are in the GN also using ARVs, also even in the patient who are not because what happened, what is, please sit down, whatever the glomerular diseases, there will be the relapse, but proteinuria might be there because already there damage to the GBM has happened, there is a damage to the podocytes has been happened. So patient might have, even in the anti-GBM patients, they might have proteinuria. So there is no indication of the immunosuppression in such patients. So we have to control this proteinuria by giving the these our non-immunological drugs. So if the patient's having the stable GFR, okay, and there is no hyperkalemia, we can uptitrate the either ARVs or ACs or SGLT2I. If the patient having no, if the patient came with known case of glomerular diseases or diabetic nephropathy having GFR of 40, okay, so you can start on ARV. If patient having proteinuria around 1,500 milligram in 24 hours, you started on the ARVs depending on how much blood pressure is having. So you started on the low dose, the low sartan, for example, you started on the 50. Patient is tolerating, there is no hyperkalemia, patient there is no drop in GFR, you evaluated. So drop in GFR usually happen within 7 days. So you have to evaluate the patient for drop in GFR after 7 days. Okay, hyperkalemia usually happen after 3 to 5 days. So after 7 days, you are starting ARV, call patient back after 7 days, and you just see a creatinine and a potassium. If it is not high, the GFR is stable, you can continue ARVs. Okay. If after 3 months, if patient having a stable proteinuria, that is around 1400 or 1200, and but creatinine is normal, there is no drop in GFR, no hyperkalemia, you can add on SGLT2I. Okay, like dapagliflozin, empagliflozin, anything. The starting dose is 10 mg or 20 mg, and then again you monitor. SGLT2I will not cause hyperkalemia; they will only cause a drop in GFR. So you again call back patient after 7 days, see a creatinine. If it is not dropping down, you continue DAPA. There are again drugs are there, like pindrinone. There is another third pillar, So you can add on that even after the patient is not having hyperkalemia. So absolute contraindication for these drugs is now hyperkalemia. So these are the third pillar we are adding now. But the first pillar is ARC, ACR, ARB, and second are the SGLT2. So that's how you have to monitor the proteinuria. But these are the SGLT2 is very we are calling it as a nephrologist, fluoxetinating the kidneys. We are calling it as a fluoxetinating kidneys. And who are the fluoxetinating? We are called the fluoxetinators. So there is actually one group we also have that is an international group, and that included a lot of peoples. If you go around and you search for some NAPGC or something, so you will find that the group called fluoxetinators. I'm the one of the member of the fluoxetinator and proud member. So so we have some interactions routinely. So these are the very good drugs and really helpful. Not even in the CKD, even in the CKD like of unknown origin, you can start SGLT2is when the patient having the proteinuria and stable GFR. Even if the GFR is dropping down, if it is less than, for example, you say you started this SGLT2I and the GFR is declining. So don't stop that SGLT2I. If proteinuria is normal, it's like stable, don't stop. When to stop this SGLT2I? When the patient goes on the renal replacement therapy, either he received dialysis or having the transplantation, then you have to stop SGLT2I. Until and unless there is no indication to stop SGLT2I. If there is a rapid worsening of the GFR, there is an indication. If there is no rapid worsening, but patient is having slowly dropping GFR, that is a natural progression, no need to stop SGLT2I. Okay, same with ARBs. If the patient is well tolerating, you no need to stop even on the patient on the dialysis. If the patient is on dialysis, you can continue ARBs to control the blood pressure. It is very good blood pressure. You know, some patient came to dialysis with having the intradialytic hypertension like 180, 200. In such patient, we are using AC inhibitors or ARBs to inhibit the RAS. Okay, so because and the response is also good, but only we have to what we look for, the patient should not have hyperkalemia. If the patient is not having hyperkalemia, they are well tolerating, you can continue ARBs, ACs even in the dialysis patient. But SGLT2I, we are not using in the dialysis or transplant patient only because there are no trials available. In the dialysis patient, trials are available. That's why we're using. For the SGLT2I, there are no trials available in the dialysis or transplant patient. That's why we are not using. Any other question? You can call me Anant. My name is Anant. Yeah. Clinical relevance, only one we have, that is the acanthocyte. That was the found with having a high specificity but low sensitivity. Rest others are they found, but that not having that much high specificity. So what we have to see only acanthocytes, and that should be more than 5%. That's all. I hope you will use this some points in your daily practice. Thank you.
The post-test link is provided. Please do your test. Lunch is provided at the venue. You can collect it when you go back.